Assalamu alaikum wa rahmatullah. Today we'll talk about anemia with pregnancy. I'm Dr. Walid Mamdouh, Assistant Professor of Obstetrics and Gynecology, Tanta University. We should start with the definition of anemia. Anemia is a condition where circulating levels of hemoglobin are quantitatively or qualitatively lower than normal. And we have to note that the level of hemoglobin required to define anemia is different from non-pregnant female to pregnant female. So, for anemia in non-pregnant women, hemoglobin should be less than 12 gram percent. But for pregnant women, hemoglobin should be less than 11 gram percent in the first trimester and less than 10.5 gram percent in the second and third trimester. Anemia can be classified according to hemoglobin level into mild, moderate, severe, and very severe, as we can see in this slide. As we noted in the first slide, I said that hemoglobin level for the definition of anemia should be less than 12 in the non-pregnant women and should be less than 11 gram percent for the pregnant woman. What is the cause for this difference? The cause is what is called physiological anemia with pregnancy, which is due to increase in plasma volume more than red blood cell volume. We can understand the condition of physiological anemia with pregnancy from this slide. As we note, these are some blood changes that occur in pregnancy. And as we can see here, blood volume, plasma volume, red blood cell volume, hemoglobin level, all these are increased during pregnancy from the non-pregnant state to the pregnant female. But the increase in blood volume and the plasma volume is more than the increase in red blood cell volume, and so the net result is dilutional anemia of pregnancy or physiological anemia with pregnancy. There are many important factors that are needed for normal red blood cell formation. These include proteins for the synthesis of the globin part of hemoglobin, some minerals, especially iron, for the formation of the heme part of the hemoglobin molecule, trace elements like zinc, copper, and cobalt, some vitamins as vitamin B12, vitamin B6, folic acid, vitamin C, and vitamin A. In addition, we need some hormones for the normal red blood cell formation, like erythropoietin produced from the kidney, and thyroxine and androgens. All these factors should be available in adequate amounts for normal red blood cell formation. What are the causes of anemia in pregnancy? This can be classified into hereditary anemias or hereditary causes and acquired causes. For hereditary causes, these include thalassemia, sickle cell anemia, other types of hemolytic anemias, and other types of abnormal hemoglobins. Acquired causes include nutritional anemia like iron deficiency anemia, folic acid deficiency, vitamin B12 deficiency, aplastic anemia or anemia due to bone marrow failure, Anemia secondary to inflammation, chronic disease, and malignancy. Recurrent infections also is an important cause for anemia. Also, anemia due to acute blood loss. This can occur in our field of obstetrics and gynecology in antepartum hemorrhage and postpartum hemorrhage or chronic blood loss. Also acquired hemolytic anemias. And here we have an example in obstetrics in the condition of pregnancy-induced hypertension and preeclampsia, which could be complicated by what's called HELP syndrome, hemolysis, elevated liver enzymes, and low platelet count. But we have to note that in developing countries, the most common cause of anemia is iron deficiency anemia. Clinical presentation of anemia depends on the severity of anemia. So, for mild anemia, the patient could be asymptomatic, but with the increasing the degree of anemia, some symptoms can happen. The patient will complain from some symptoms. These include pallor, easy fatigability, difficulty of breathing, palpitation, and some signs like pallor, tachycardia, tachypnea, and with more and more severe anemia, the patient can develop manifestations of heart failure. So we can hear bilateral fine basal lung crepitations, raised jugular-venous pressure, pitting edema over the legs and abdominal wall, and also sometimes we can find hepatosplenomegaly. Also, because of the tachycardia and the effects of anemia, sometimes you can hear a hemic murmur on the heart, and this should put in the differential diagnosis from heart disease with pregnancy. Other manifestations that happen more frequently in iron deficiency anemia, like glossitis, stomatitis, and chelosis. All these signs can be noted in a case of anemia. Is anemia an important issue in pregnancy? Of course, yes, because it has a significant effect on the maternal and fetal condition. Regarding the mother, if there is anemia with pregnancy, the mother will start to suffer from lack of energy, general weakness, easy fatigability, poor work performance. Also, for the pregnant and anemic female, any amount of mild bleeding, either antepartum or postpartum hemorrhage, can have serious effect on the general condition of the anemic and pregnant female. Also, with the increased severity of anemia and the effect of pregnancy, both can endanger the cardiac function of the mother and predispose to cardiac decompensation and cardiac failure. Anemia also predispose to infection, especially postpartum infection or peripheral sepsis. Also, anemia has been linked with the development of preeclampsia and preterm labor. Regarding the fetus, a link also has been found between anemia and preterm delivery, small for gestational age, increased perinatal morbidity and mortality. Later in life, there will be development of iron deficiency anemia in the newborn, cognitive and affective dysfunction in the infant, and there is increased incidence of diabetes and the cardiac disease later in life. Regarding iron deficiency anemia, does the pregnant female need extra iron during pregnancy or not? Yes, during pregnancy, a total of 800 to 1000 milligram extra iron is required during the whole pregnancy. Of these, 300 milligram are needed for the fetus and 50 milligram for placenta, 4 to 500 milligram for the increased red blood cell mass during pregnancy, 250 milligram iron lost during delivery, and about 220 milligram for basal losses. On the other hand, pregnancy saves some iron for the female due to cessation of menstruation and the contraction of blood volume after delivery. Regarding the daily requirements of iron, we have to note that normal diet contains about 10 to 20 milligram of iron, but of these 10 to 20 milligram, about 5 to 10% is absorbed, which constitute about 1 to 2 milligram. Okay, so for pregnancy, for the extra iron requirements that we mentioned in the previous slide, there is a need for additional iron of about 2 to 3 milligram per day in early pregnancy and up to 6 to 7 milligram per day in late pregnancy. So for this extra iron, we need to increase the daily supplement of iron to up to 40 to 60 milligram per day. Regarding iron absorption and transport, for the ingested ferric iron, this is it changes to ferrous iron by the effect of gastric HCl. When this reaches the duodenum, it will meet apoferrin secreted in the bile from the liver, and it will combine ferrous iron to form transferrin. Transferrin will be absorbed from the cells of the intestinal mucosa to be released into the circulation as plasma transferrin, and plasma transferrin will conduct iron to the different target organs or stored as ferritin. This figure shows iron absorption and transport. How to investigate a case of anemia and iron deficiency anemia? Of course, we have to start with complete blood picture to know hemoglobin level and hematocrit value. This should be done at first visit at 28 to 30 weeks and at 36 weeks of pregnancy. In CBC also, we have to check reticulocytic count, which normally should be between 0 to 2%. Increase reticulocytic count, which is called reticulocytosis, indicate overactive bone marrow, and this could be found in certain situations like cases of hemolytic anemia following acute blood loss, and in cases of iron deficiency anemia on treatment. So in case of iron deficiency anemia, one of the markers of improvement on treatment is increase in reticulocytic count. Also in CBC or complete blood picture, we have to note red blood cell count and hematocrit value, and red blood cell indices like mean corpuscular volume, mean corpuscular hemoglobin, mean corpuscular hemoglobin concentration. From these indices we can know the type of anemia like microcytic hypochromic, normocytic normochromic, or macrocytic hyperchromic. In case of iron deficiency anemia, what are the possible investigations that help us to confirm the diagnosis? As we know, iron deficiency anemia is microcytic hypochromic anemia. So we will find hemoglobin concentration will be lower and it should be less than 11 gram percent as we mentioned before. All red blood cell indices like mean corpuscular volume, mean corpuscular hemoglobin concentration will decrease. Peripheral blood film will show the microcytic hypochromic red blood cells. Also, other investigations specific for iron deficiency is decrease in serum iron below 60 microgram per deciliter. Total iron binding capacity will be increased. Transferrin saturation decrease. Serum ferritin decrease. Free erythrocyte protoferrin will increase. These are very important investigations for the diagnosis of iron deficiency anemia and will help us to differentiate between it and hemolytic anemias as we will see in later slides. These are the equations used to calculate mean corpuscular volume, mean corpuscular hemoglobin concentration, and mean corpuscular hemoglobin. Peripheral blood film or peripheral blood smear will help us to know the type of anemia to confirm the diagnosis. So this could vary from normal smear, normocytic, normochromic. In case of iron deficiency anemia, there will be microcytic hypochromic red blood cells, variation in the size which is called anisocytosis, variation in the shape of red blood cells. In sickle cell anemia we will find the sickle cells. In thalassemia we'll find what's called target cells. In aplastic anemia there will be low or no count. So this is the importance or the help of peripheral blood film in confirming the type of anemia. Classification of anemia according to the size of red blood cells. This table will help us to differentiate between two important causes of hypochromic microcytic anemia, which are iron deficiency anemia and thalassemia. In both conditions there will be anemia, decreased hemoglobin level, decreased all red blood cell indices. So to differentiate between both conditions, we will find in case of iron deficiency anemia there will be reduced serum iron, reduced serum ferritin, increased total iron binding capacity. But for thalassemia, all the previous investigations of serum iron ferritin will be not reduced, but there will be increase of abnormal hemoglobins like hemoglobin F and hemoglobin A2 and hemoglobin erythropoiesis. So this is very important because giving iron therapy in all cases of hypochromic microcytic anemia is not a suitable treatment, because in case of thalassemia there will be no response on iron therapy, but in cases of iron deficiency anemia there will be marked improvement in anemia after giving iron therapy. Treatment for iron deficiency anemia. This can be done by improving diet rich in iron like fruits and leafy vegetables. Of course, heme iron from the animal food is better absorbed. Food supplementation with iron. Iron and folic acid supplementation in young girls and during pregnancy. Some elements help iron absorption like citrus fruits and vitamin C. To get the maximum benefit from supplemented iron, we should maintain general hygiene and treat warm infection. Also, we should avoid tea, coffee, calcium phytates, phosphates, and oxalate. Iron supplementation in pregnancy. The daily requirements for iron during pregnancy is about 40 to 60 milligram elemental iron and about 400 to 500 microgram of folic acid during whole pregnancy and for 3 months after that. But in cases of iron deficiency anemia, we need therapeutic doses of iron up to 180 to 200 milligram per day. What about the route of administration? We give iron orally, intramuscular, intravenous. This depends on severity of anemia, gestational age of pregnancy. Like in late pregnancy, we don't have enough time for correction of anemia, but in early pregnancy we have plenty of time, so this will make the decision about the route of administration of iron. Also, compliance and tolerability of iron. Some patients cannot tolerate oral iron, and so in these patients we have to shift to another route of administration like intramuscular or intravenous infusion. Also, there are various preparations for iron like iron fumarate, gluconate, succinate, sulfate, but there is no scientific evidence that any particular brand is better. Also, if the patient cannot tolerate iron, we can use what's called carbonyl iron. We have to know that oral iron have some side effects that can make the patient stop oral iron. These side effects include nausea, vomiting, gastritis, constipation, and sometimes diarrhea. We have to know that iron supplementation is not recommended in the first trimester except if there is severe anemia, because there is a link between iron administration in the first trimester and rate of miscarriage, rate of birth defects. These are the different forms of oral iron and dosage. Some important issues for oral iron. What are the contraindications to oral iron? These include intolerance to oral iron, so the patient cannot tolerate the side effects that we mentioned before, and in cases of severe anemia in advanced pregnancy. So in this case we don't have enough time to use oral iron to correct anemia, and we have to shift to another route. What are the manifestations of failure? What are the causes for failure of response to oral iron? Like a case of anemia, we are giving iron, but there is no improvement in anemia. This include inaccurate diagnosis, as we mentioned before. If a case of hypochromic microcytic anemia, and this case is thalassemia, not iron deficiency anemia, so it will not benefit from giving iron therapy. Another cause is faulty absorption of iron, continuous blood loss, so we are giving iron to correct from one side, but there is blood loss from the other side. If there is associated infection or associated folic acid deficiency. On the other hand, what are the indicators of response to iron therapy? Of course, there will be improvement in the general condition and well-being of the patient, no easy fatigability, better performance at work, The general look of the patient and pallor will improve. Improvement in the patient appetite. Also there is rise of hemoglobin, but we have to know that this rise in hemoglobin do not start immediately, but it has to take about 3 weeks to observe this improvement. Another marker, as we mentioned before, is increase in reticulocytic count, but this will occur within 7 to 10 days. In case of parenteral iron transfusion, the dose of iron transfused is better to be calculated using a specific equation based on a patient weight in kilogram multiplied by what is called iron deficit multiplied by 2.2 plus 1000 milligram for iron stores. What is iron deficit? Iron deficit is the difference between normal hemoglobin and patient's hemoglobin. So this is the equation used to calculate the dose of iron that should be given by the parenteral route. Also, we have to note that there is no advantage in using parenteral iron over oral iron if we have plenty of time to correct anemia and if the patient can tolerate oral iron. For parenteral iron, we have different formulations as iron sorbitol injection. This should be given only by deep intramuscular injection, but some disadvantage including pain and skin discoloration at the site of injection. Iron dextran, this can be given by intramuscular or intravenous route, but there is increased incidence of allergic reactions up to anaphylaxis. Iron sucrose can be given by intravenous route with lower incidence of allergic reactions. Examples of different available forms of parenteral iron. What are the indications for blood transfusion? There are some indications like case of severe anemia first seen in late pregnancy, so we don't have enough time to correct by the oral or parenteral iron. In case of severe anemia with manifestations of anemic heart failure, in cases of acute blood loss like acute antepartum hemorrhage and the cases of postpartum hemorrhage, in cases of no response to oral or parenteral iron, and in cases of associated infections. What about the management of labor in anemic patient? As we mentioned before, anemic patient has difficulty of breathing, have increased heart rate, tachycardia, increased overload on the heart, increased the cardiac output, defective oxygenation. So there are certain precautions for this kind of patient or not. Of course, labor should be supervised in this patient. We should be ready with blood, either whole blood or packed red blood cells, and should be cross-matched. Patient should have IV line ready for any blood transfusion, but we should avoid volume overload as we mentioned, because this patient has increased cardiac output and increased the load on the heart, so avoid fluids as much as possible. We should give an intermittent oxygen by mask in this anemic patient. Also, we have to take all the precautions to prevent infection, because we mentioned that the anemic patient is susceptible for infection, so we have to follow all strict aseptic precautions, minimize PV examinations, prophylactic antibiotics should be given. Also, we have to be ready for all measures to prevent blood loss during delivery. And finally, in decompensated patients, we should give diuretic therapy to decrease the overload on the heart. During second and third stage of labor, second stage should be shortened by forceps or ventouse. There should be active management of the third stage of labor in order to minimize blood loss. As we mentioned before, even normal blood loss may be poorly tolerated by the anemic patient. So we have to be ready by all measures to decrease blood loss, like oxytocin, prostaglandins like misoprostol, but we should note that intravenous methargine is better avoided or contraindicated. Another important thing is to give intravenous diuretic after delivery of the placenta to decrease the cardiac load, because the placental blood flow will be shifted into the maternal circulation after delivery of the placenta. So in order to decrease the cardiac overload, we have to give intravenous diuretic to avoid cardiac decompensation. After delivery, this patient should be encouraged for early ambulation, because we know that the anemic patient will be exhausted and there may be prolonged recumbency in bed, which makes her susceptible for thromboembolism. So we should encourage early ambulation of this patient. We should watch for sub-involution of the uterus, development of infection as peripheral sepsis, development of congestive heart failure after delivery, manifestations of thromboembolism. This patient should be given hematinics for up to 3 to 6 months after delivery. We should encourage spacing of pregnancy for at least 2 years to improve the general condition of the patient, and we should give her proper counseling about the different available contraceptive methods. Thank you very much, and we will talk in the second part of this lecture about abnormal hemoglobins, of which the most important are thalassemia and sickle cell anemia. Thank you.